When a new pathogen emerges, clinical focus naturally turns to the symptoms it causes in a single patient. But the true trajectory, velocity, and reach of an outbreak are governed by rigid mathematical rules. This blueprint maps the 4 foundational parameters that control every epidemic: transmission, velocity, dispersion, and surveillance. By tracking these numbers, public health teams can move past treating individual cases and actually predict and suppress the spread of a pathogen across an entire population. This split screen illustrates transmission potential. On the left is the basic reproduction number, or R0. This is a pathogen's biological speed limit, the maximum number of secondary infections a single person will cause in a completely susceptible population with 0 interventions. On the right is the effective reproduction number, or RT. This is the real-time operational metric. It measures the average number of secondary cases after factoring in existing immunity and active policy interventions. We can actively compress that RT value. Deploying physical barriers, like this dedicated isolation ward, mathematically reduces the number of contacts an infected person makes. An outbreak is only under structural control when those interventions successfully force the RT value below 1.0, breaking the chain of transmission. This timeline models the speed of an outbreak. The top track represents the serial interval, the clinically observable time between a primary case feeling sick and their secondary contact showing symptoms. The bottom track shows the generation time. This is the actual biological interval between the 2 moments of infection, which often happens invisibly, days before anyone feels ill. As this warning box highlights, when the generation time is shorter than the serial interval, we hit the presymptomatic transmission trap. People shed the virus and infect others before they ever show a symptom. This graph tracks how that invisible chaining rapidly shrinks the outbreak's doubling time, reducing the days it takes for total cases to multiply by 2. A collapsing doubling time serves as the definitive early warning signal that hospital beds and ICU capacities are about to be exhausted. This scatter plot visualizes the overdispersion parameter, or K, which measures spatial heterogeneity. The left side shows a high K value near 1.0, where a virus spreads evenly and uniformly from person to person. The right plot shows severe overdispersion, where K drops below 0.3. Here, a tiny fraction of infected individuals drives massive, highly concentrated superspreading clusters. To quantify the micro-risk inside a dense cluster, like a poorly ventilated room, we calculate the secondary attack rate among that group of close contacts. Identifying a low K value requires public health officials to shift away from broad community advisories and implement highly targeted interventions in those specific microenvironments. If a region's test positivity rate suddenly skyrockets, it means the surveillance net is failing, missing the majority of infections, and only capturing the sickest patients. This data funnel illustrates the diagnostic trap. Clinical surveillance naturally overrepresents the severe tertiary hospital cases at the narrow bottom, while entirely missing the invisible community spread at the wide top. Drawing mortality data only from that narrow bottom layer yields the case fatality risk. Because it ignores undetected cases, this metric is artificially high due to ascertainment bias. Factoring in the wide top layer gives us the infection fatality risk, which uses the true denominator of all infections, both severe and undetected. Relying on the infection fatality risk is the mathematically valid way to assess true population-level mortality and prevent the artificial inflation of a pathogen's deadliness. Clinical observation tells us what a pathogen does to an individual host. Biostatistical metrics reveal exactly what that pathogen is doing to the population. This final blueprint summarizes the parameters. By mastering these numbers, we transition from reactive medical observation to proactive structural containment.